Hi guys, I'm Crystal Broussard. I am a family doctor down in Texas, and I started doing weight loss medicine back in my practice in 2006, so for a long time. Some of you guys have been asking, how do I talk to my patients about the GLP-1 agonist? So I wanted to kind of give you the down and dirty and actually share a lot of this information with the patients, and it really just depends on what questions they have as well. So the first thing I do is I actually share my own story very quickly. I basically tell them I'm a family doctor, specialized in weight loss, been doing it for 18 years. I've lost 100 pounds myself, so that's what makes me passionate about it. Not that everybody's gonna have the same story, but just a little snippet of why you're doing what you're doing so that the patient feels like there's a connection with you. Why do I focus on the GLP-1 agonist? Because they're the best we have. I mean, it's an exciting time to be in weight loss medicine because we actually have medications that work, which is amazing. So these are kind of the things that I talk to the patients about. For patients who are actually concerned about the medication and the safety, I let them know that these medications have actually existed for almost 15 years. So Byetta actually came out in 2009, so we have a long safety profile on them. The first medication marketed for weight loss was 9 years ago, so it was Saxenda back in 2014. Was not as successful as what was hoped for a few reasons. One, it's a once a day injection, so patients didn't really want to do that. Two, back in 2014, you couldn't get an insurance company to pay for medication no matter what, so if you can't afford the medicine, you can't take it. And then the weight loss was about 5% body weight on it, and patients didn't feel like that was enough to be doing daily shots. I explained that over the course of the years, our diabetic medications have gotten even better. Now we have once a week shots. And as those medications like Ozempic and Trulicity and Bydureon got even better, we also saw better weight loss with them. So I talk about the fact that Ozempic was remarketed as Wegovy, same molecule, same manufacturer. The only difference in Wegovy is it goes up one dose higher because we know that our studies show the higher the dose, the better the weight loss. At this moment, I say at this moment because there's other things coming out, at this moment, Wegovy is the most effective weight loss drug we've ever had on the market by far. We're looking at about a 15 to 17% body weight loss, so we've never had anything like this before. And I do talk to patients about that if they are questioning how it works, you know, what it does, that type of thing. I do tell them, especially if Wegovy is covered, that there is a new medication that is likely going to be out by Eli Lilly. I talk about the fact that Mounjaro is the diabetic medication. Eli Lilly is remarketing, should be out by the end of the year, that medication as a weight loss drug. And then at that point, we're actually seeing 22-ish percent body weight loss on average, but actually the majority of patients see even more weight loss than that. So I think it's important to understand that there are more and more medications coming out. The newest ones on the horizon that are actually combining 3 different peptides. We're gonna be getting more than 30% body weight loss, and so we're finally seeing weight loss in realms that rival bariatric surgery. So that's super exciting. Then I talk a little bit about what the medications do. So the fact that they work by slowing gastric emptying and treating insulin resistance, that it's thought that the majority of Americans have insulin resistance. In my opinion, that is the reason that these medications make such a difference. I can treat somebody's appetite and make them eat less with phentermine, but I can't treat their insulin resistance. I do find in my own practice that the patients with insulin resistance respond the fastest as far as weight loss, but that's a personal finding for me. Talk about the fact that all the side effects are due to this slowing of the gastric emptying, so you can get anything: nausea, vomiting, diarrhea, constipation, abdominal pain, bloating, reflux, heartburn. Most patients, if they get something, they get a little bit of nausea for a few days. It tends to get better week by week, but each time we go up on the dose of the medicine, it may recur again. I talk to them about the fact that if it ever gets to a point where it's too much, we back down. They actually do need to be able to eat. Really important, I actually set this up from the beginning on patients, is that I talk to them about the fact that these medications are not Band-Aids. All of our studies right now are showing that they are most likely going to be a long-term medicine. We don't know what that looks like for everyone. I have some women who are maintaining on once a week shots, some on once every 3 week shots. I have questioned personally if things like Rybelsus, so the oral form of semaglutide, which we know is not as effective at weight loss, I have some questions. Well, will that be enough to maintain? We don't know yet. I talk about the fact that the contraindications, pancreatitis, family history of medullary thyroid cancer, wanting to get pregnant in the next like 3 to 6 months, that's kind of a soft call. Anything under 3 months I wouldn't do. 3 to 6 months we probably can actually help their fertility, so that's kind of a conversation to have with the patient. And then one thing that I talk about that we have seen at our practice, which is super important, and we're not going to have a way of monitoring it, is that a big side effect of these medications is muscle loss, because we're seeing malnourishment in our patients from these medications the same way we've seen it for years in the bariatric surgery patient population. And when that happens, they get tired, they feel weak, they're losing their hair. So I think it's really important to talk to the patients from the beginning that they really need to be getting that. We've known about this threshold for a long time, since 2010. It hasn't changed, but we need to reiterate that they need to be getting at least 30 grams of protein 3 times a day to protect their muscle. In my own practice, I preach protein all the time, and because I monitor the body comp, I'm actually able to pull back on their medicine if we need to, if they're not eating enough. So I just think that that's an important thing to bring up in case patients are telling you that they're so nauseous. And it's funny, it's a woman thing. They're like, I'm so nauseous, but I'm losing weight, I'm not going to change anything, I got it. And I'm like, no, we have to be able to eat. So I think that that's important to listen to the patients about. So again, super quick, down and dirty, the things I talked to you about with my patient. And it takes a while, like it usually is a 10-minute conversation with a patient on the medications, but I think it's important that they know what it is, what it does, why we do it, why it's the best, what the side effects are, and what the long term looks like on the medicine. So hopefully that helps. Thanks.